It's Florence. Welcome to the theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter, anyone else that's interested, the theobspod is for you. Episode 15. Guidelines. Through the course of my career, there's been an ever-increasing emphasis on evidence-based medicine. Fantastic, you might say. Obviously, we should be treating people according to the evidence. And that is true. But actually, evidence-based medicine can be quite difficult. Evidence is often on the basis of large numbers of patients in clinical trials that may or may not accurately resemble the patient we have in front of us. And not everything is on the basis of evidence. Not everything lends itself well to your double-blind, randomized controlled trial that perhaps is the gold standard. Some of the things that we do to show that we're running a good quality service, so compliance, such as checks by the Care Quality Commission, CQC, or the scheme that trusts pay into, Clinical Negligence Scheme for Trusts, CNST for short, encourage us to be compliant with national guidelines, and we have to justify and demonstrate the use of things like NICE guidance to try and ensure that we're offering a standard level of care. So this can be hugely beneficial in making sure that a woman in one hospital can receive the same standard and level of care as in another hospital in a different part of the country. And it also can be very beneficial for more junior staff, those learning and training to understand how we treat certain conditions or how we manage certain situations. It also can be useful for consistency, so that if a woman sees one member of staff, she'll be told the same information and a consistent standard of information as if she's seen by another member of staff, so that you avoid giving contradictory advice and you avoid confusing a woman by giving her different information. So don't get me wrong, evidence-based medicine, yes, big tick, definitely a good thing to do. But it's how you apply the evidence to an individual that is more difficult. And that's what I'm going to talk about today when I'm talking about guidelines. So guidelines come in many forms. So there are national guidelines, such as NICE, the National Institute of Clinical Excellence. And there are guidelines produced by clinical bodies. So for me in obstetrics, a lot of guidance is published by the Royal College of Obstetricians and Gynecologists. And they have different sorts of guidance. And then that guidance is taken and applied at local level. So every hospital will have its own guidance, its own version of the NICE guidance or the RCOG guidance on how they plan to implement and apply that guidance in that particular maternity unit. And that might sound bizarre, because you would think with some national guidance, well, obviously everyone should just adopt that and do that. But actually, it depends on what your resources are. So if guidance says everyone should have an ultrasound scan, well, in reality, can you implement that? Have you got enough sonographers for a start? Because they're a highly trained, highly qualified group of staff of which there is a national shortage. Have you got the scan machines? Have you got the scan rooms? Have you got the capacity within your service? And that's before you've even thought about the cost. So putting in a guideline that someone should have an additional ultrasound scan may or may not be easy to implement. And that's just a small example. So it's not quite as straightforward as everyone immediately implementing every national guideline that there is going. And it's also not quite that simple because different clinicians have different experiences and different perspectives, and different hospital trusts have different patient cohorts. For example, with gestational diabetes, so diabetes in pregnancy, we know that certain ethnic groups of women are more at risk, and you can choose either to screen your whole population or you can choose to screen those women that are at risk. Well, if you have a population who have a very high demographic of those high-risk groups, then it may be simpler and more straightforward to screen your whole population. So every pregnant woman to have a glucose tolerance test, that's a glucose blood test, at a certain point in her pregnancy. Whereas if you are working in a unit where there's a low prevalence and not many of your population fall into the at-risk groups, it may be more sensible to try and target those women that are at risk and just screen those women. So there are lots of local things to consider when you apply national guidance. The other thing that's important to consider is when we talk about evidence, what do we mean? So there are different levels of evidence, and helpfully in the RCOG guidance, they always put at the end of their guidelines, which are called green top guidelines, just simply for the reason they're published with green band at the top. No idea why, but anyway, we all call them green tops. So the green tops always have a bit at the end that talk about the grades of evidence. These go from A through to D and also a tick. So A will be really good, high caliber evidence. So a proper randomized controlled trial that's of very high caliber, possibly a meta-analysis. That's where you've added lots of different research studies together and done an analysis. So that'll be really, really high caliber evidence. And then that goes all the way down through to D, which is evidence that wasn't properly analysed, might be case reports, case series, more anecdotal evidence and expert opinion. So actually not very scientific at all. And then the tick is a good practice point. So recommended best practice based on the clinical experience of the guideline development group. So actually there may be no evidence for a tick, but it's something that the guideline group of professionals feel is a good practice point. So kind of generally accepted practice. So why am I talking about these different levels of evidence? Well, the reason is that when we apply the evidence and apply our guidelines to individual women, we need to understand what we're talking about, whether we're talking about chalk or cheese. How strong is the evidence that supports what we're suggesting this woman should do? To take a common problem, let's take postpartum hemorrhage. So bleeding after the birth of the baby. A postpartum hemorrhage is categorised as more than 500 mils blood loss. So that's more than a pint of blood loss after birth. If you look at that green top from the Royal College, some of the recommendations are evidence level A. So really, really good quality trials have been done that recommend that we should offer all women a drug to help the womb contract and the placenta separate in the third stage of labour. So all women are routinely offered syntocinon, the hormone, to make that happen. And that's because the evidence is level A, really good. Then, within the same guideline, you've got evidence level D, so not good at all, case studies, case reports, expert opinion. All women with known risk factors for postpartum hemorrhage should birth in a hospital with a blood bank on site. Well, that's kind of common sense, isn't it? You can see why that's come out as expert opinion. But is there evidence to support that? Well, not good evidence. No one's ever done a trial where you put one woman in a hospital with a blood bank, one woman in a hospital without a blood bank. Don't even know if that would be an ethical study to do. But it's still important advice. It's still important to have in the guideline, but the evidence level for it is poor. And the reason I'm going on about this in great depth is how we apply guidelines should take this into account. But sometimes we just take a guideline, and remember, it is exactly that, a guideline. It's to guide us, and we turn it into what women can and can't do. And women interpret what we say as what they are or are not allowed to do. So when I started doing work on maternity experience, I discovered that a lot of women were commenting that they were not allowed to have their baby on the birth centre, or not allowed to have skin to skin, or not allowed to have two birth partners. And when you ask staff, they don't feel that they end up telling women what they can and can't do. But that's how women perceive it. So we need to be careful when women want to do something that we don't get kind of sucked into trying to keep them on track. We need to think about their personal experience, their personal history, their personal individualised care, and what for them is the right choice. And the information we give them needs to be information from guidelines so that we're giving them really good high calibre information. But when women want to go, in quotes, outside of guidelines, that's okay. That's their considered choice. That's their assessment of their priorities. That's their assessment of the risk or benefits. So sometimes women, in inverted commas, outside of guidelines becomes a label. And sometimes there can be a consultant midwife or senior midwife whose job it is to care for and help make plans for women outside of guidelines. And that's good. That's good that those women are getting that individualised care and that they're having a proper think through the pros and cons of what they do and don't want to do. And we're really giving them good information on which to make their decisions. But that idea of outside of guidelines, I just find a little bit peculiar. It's a little bit like going on a train track and you've derailed. You're outside of guidelines. Sometimes staff find it difficult to respect choices outside of guidelines that are more unusual. And we find it difficult to accept choices that we wouldn't make. And that's to do with our own inherent bias and also the bias of the system. So an example might be a woman who doesn't want screening for trisomy 21, Down syndrome. So she might decline screening. She doesn't want screening. She doesn't want the ultrasound measurement and blood test that's routinely offered. And once she's turned that down, rather than staff accepting her choice and accepting that she's made an educated decision and that she's been given the information about the condition and about the screening and what it involves and what the risks and benefits are, rather than respecting that decision, we can sometimes repeatedly ask her, are you sure you don't want screening? We could still do screening. Why don't you want screening? Oh, I can see you don't want screening, rather than accepting what she's actually decided. And this, when I say this is not just staff, but the system, you've got to remember that there are targets from public health about offering women screening and the uptake of screening. So as a public health issue, yes, that may be the right thing to do. It may not be. Times have changed a lot, after all, in what we feel about Down syndrome and what we feel about different medical conditions that we screen for. But we need to accept the woman's decision. I've also seen this in women who don't want to have blood tests. So we do routine blood tests during pregnancy, and they're all for good reason. They've all been developed over a long time to assess the health of the mother and the health of the baby, and they are important blood tests. And I have some women who refuse to have them, most often because they have an extreme needle phobia. And the response from staff at the hospital can often be, well, how can we make her have them? So has she been to have CBT to help her cope with having the blood tests? Have we explained to her the importance of having the blood tests? Have we told her the risks of not having the blood test? And we can get very, very focused on the blood test, so that at every appointment she's being challenged, why hasn't she had the requisite blood tests? And how can we make her accept the blood tests? And if we do it in this way, or with this sort of needle, or with local anaesthetic, can we get her to accept the blood tests? Rather than focusing on her overall care in a more holistic way. I think experienced clinicians are more likely to individualise risk and think about choice, rather than inadvertently coercing a woman. No woman chooses to put herself and her baby at risk. How we talk to women can really influence their decision making. And if a woman feels like she is being told that she is being selfish and that she needs to put her baby first, she will be guilted into taking action that she may later on regret. Having an adult-to-adult conversation with women about what the guidance is nationally and what the guidance is locally and what the basis for that guidance is, so that she can make an educated decision, is really important. An example I frequently come across in my clinic is the suggestion of induction for maternal age, so induction of labour. And we offer induction to women who are over 40 at 39 to 40 weeks rather than 41 weeks and 5 days. And that's because there is a higher risk of stillbirth in women who are in their 40s over women that are in their 20s or 30s. And that isn't that the risk screams up immediately they turn 40 on their 40th birthday. It's a gradual incremental rise. And it's only that we as a hospital have translated that into, realistically, what we could offer is induction for age 40 and above, because that's 6 or 7% of our women. That's a realistic number that we can induce given our service, given our workload. And that's a sensible time to induce that doesn't increase the risks of cesarean or intervention in their labour. But sometimes this guidance, this offer of induction gets translated into you must have an induction or your baby will die. Whereas the risk in reality may be 4 or 5 per 1,000, which for any individual woman is small. So I often get people sent to me for a second opinion, often almost as if they've been sent to the headmistress. This woman is declining induction. This woman is asking for something out of the ordinary. And often the women arrive in my clinic quite stressed. They've been made to feel they're doing something wrong for them and their baby. And what I do is try and have a considered discussion about, well, individually for them, what do we know about their pregnancy to date? What do we know about their overall health? What do we know about how their baby is behaving? And I try and ask them, what did you come to the clinic hoping for today? How long do you want to wait? Are you wanting to wait for spontaneous labour? Are there things that we could do to help you during that time while you're waiting that would reassure you and reassure me that things are okay? And try and be a bit realistic about how we apply that guideline and that offer of induction, rather than it being translated into being mandatory. In the past, we used to quite often get women to sign a discharge paperwork if they were taking discharge against medical advice, so leaving the hospital against medical advice, or signing something saying they wanted to go against our medical advice. And that is, thankfully, very rare these days. It feels very contradictory in terms of autonomy. A woman is an autonomous being. She doesn't need to sign anything to be able to disregard what we say to her. It's defensive medicine. Don't get me wrong. Sometimes women want to do things that literally make my hair stand on end. Those of us involved, and I often look after these women in conjunction with the consultant midwife or other senior midwife, we will literally be waiting day by day for something to happen, day by day for the safe birth, day by day hoping that the woman and the baby will come through unscathed. For example, over the years, I've had numerous women with twin pregnancies who are declining induction of labour, don't want to be induced. So twin pregnancies are of many different types, and I'll talk about that in another episode. But dichorionic diamniotic twins, those are the least risky sort of twins that have their own placentas and their own sacs. There's a recommendation that at 37 weeks, there should be an elective birth, whether that is through induction of labour or caesarean section. And that is because there's no increase in adverse outcome, but birth beyond 37 weeks and 6 days has an increased risk of fetal death. When you drill down into what sort of evidence is this and what's been taken into consideration in the NICE guidance on this, you can click on 122 pages of analysis of numerous studies on which this advice has been made, taking into account the increased risk of stillbirth and neonatal death. And it's true that the best studies still show a low risk. So there's a low risk of one of those twins dying of 27 in 1,000. 27 in 1,000 is still relatively low. But if you look at the charts, the pooled incidence graphs, you can see that there's a very steep rise in the curve at 37 weeks. The rate of fetal death takes off exponentially almost. So there are some things that frighten me, make me lose sleep, make me worry. And of course, often the outcome is good Every now and again, someone didn't take your advice and they pay a very heavy price. And women who go outside guidance, don't get me wrong, sometimes it's about additional things that women want done that we wouldn't routinely recommend. An example might be Group B strep screening in pregnancy. Group B strep is a bacteria that's commonly carried by women in the vagina, can cause severe neonatal infection, can cause neonatal meningitis and death, but the evidence level is level D, so not very good, that this should not be universally offered. So at the moment, if a woman wants to be screened for Group B strep, she can organise that. She can pay privately and do that. And we can give her that advice, even though nationally, the national guidance currently is don't universally screen everyone. Another example might be women coming from countries where they routinely screen for toxoplasmosis, another infection that can detrimentally affect pregnancy outcome. Again, this isn't something we would routinely screen for. It isn't something that if we detect it, there's much that can be done. But it is something that some women will request because culturally where they come from, that is routine care. So guidelines, it's not just about refusing things. It's about educated decision making and making choices, whether those are positive or negative. So for today's zesty bit, what I want to say is guidelines are just that. They are a guide. Women can choose to decide to do otherwise. They don't have to follow the guidance. We have to follow the guidance. We have to guide them and explain that this is the guidance, whether it's local or national, and this is the evidence underpinning that, and this is the way we can support them with one decision or another decision, and these are the choices open to them. And only that individual woman can decide what her priorities are and what her view is of the risks and benefits of whatever we're suggesting. So when we talk to women, we need to consider, are we truly serving her or are we serving ourselves? Is it fear of litigation, fear of problems? Is it fear of doing something wrong that drives us? It's also about where the power lies. The power should lie with the woman that we're advising, not with ourselves. It shouldn't be us telling her what to do. It should be us giving her information so she can make her choices. The other excellent piece of advice on the Royal College of Obstetricians and Gynecologists green tops are for women. They have a really good series of patient information leaflets, and these recommend that pregnant women ask 3 questions. 1. What are my options? 2. What are the pros and cons of each option for me? And 3. How do I get support to help me make a decision that is right for me? And I think that's really pertinent for us to remember as medical staff and midwifery staff. We are there to support, to help the pregnant woman make the decision that is right for her. So I do hope you've enjoyed listening to the theobspod. If you have, do like, subscribe, or leave a review, and join me again to explore more about the life of an NHS obstetrician. I'm finding it really exciting to have people listening and give me feedback about what they've found interesting. So please do recommend the theobspod to other friends, colleagues, or people who you think might find it interesting. I'd love it if you'd share with me what you've enjoyed about listening and if you've done anything differently as a result. I can be found on Twitter at FW and at theobspod. And please do check the MatExp hashtag MATEXP, and the website matexp.org.uk for more information and ideas on how to improve women's experience of maternity care. Finally, I'd like to reassure you that I take confidentiality very seriously, and although I'm talking about experiences from my working life, I'm taking great pains to make sure that I anonymise the stories and talk in more general terms so that I keep confidentiality of my women I currently care for and have cared for in the past very safe. Many thanks for listening.